Welcome to Startup Health TV, where we celebrate the entrepreneurs and innovators who are transforming health. I'm your host, Logan Plaster, with my guest here, Devina Desai, CEO of Kinometrix. Devina, great to see you, as always.
You too, Logan. It's always nice to talk to you.
All right, so you've got this innovative platform using artificial intelligence to help decrease falls in the hospital. So break it down for us. What is Kinometrix?
Sure. So what we are is a precision patient safety platform. The reason we started addressing falls first is because it is the most frequent preventable condition in a hospital.
Okay.
It impacts 1 million patients each year. And then their pathway or their diagnosis, prognosis just goes down from there. There's 11,000 deaths preventable attributed to falls each year.
11,000 preventable because of falls. Talk to me about the macro problem of preventable problems in general in the hospital.
So preventable problems, pressure injuries, falls, hospital-acquired infections, they end up costing the healthcare system around $98 billion each year.
98 million.
Billion,
sorry.
Billion.
Glad I got that.
And falls itself is a $7 billion problem.
Wow.
Because it's a never event, as deemed by the Centers for Medicare and Medicaid Services, it is not reimbursed by Medicare.
Okay.
And in the value-based bundle payments, it's technically not reimbursed by health insurance companies.
So when you make a
either.
mistake, all of a sudden that medical bill is on the hospital.
That is on the hospital.
Okay.
It can't be passed.
Even though it's relatively common. It's happening pretty often.
It shouldn't be, but it does.
Yeah.
The fall rate is somewhere between 1.04 to 2.07.
Now, you're the CEO, not the founder of this company. You have an interesting pathway towards Kinometrix. Tell me kind of what you were doing before you came into the company.
Sure. So before I joined Kinometrix, I was with Innova Health System. It's a regional health system in Northern Virginia. And I was working with their research office. I was working on patient safety projects, on projects in nursing research, and then clinical services. So a broad spectrum that covered patient safety issues, patient harm issues. Sepsis was one of the projects I worked on. And Kinometrix was one of the companies I was supporting as they were pivoting from a medical device they had developed to what they wanted to address, falls in hospitals. And from that, and once I began working with them, there was just a transition came naturally both from the company and a group of investors that said best to transition the company to someone that understands the hospital system and the problem from within.
What was that journey like to go from the patient safety side of the hospital to a startup that's addressing those issues as a third party?
It was a rough journey. I'm not a startup founder. I'm not a trained CEO, didn't go to business school. So just learning the little nuances of running a company, what you need to focus on, where now your customer is the most important, of course, but you're not thinking from a health system perspective.
Yeah.
Now you're thinking from a startup perspective that's selling into the health system.
But you've got this superpower of really knowing what the conversation is that's being had on the hospital side.
Yes.
Because it was you.
Understanding who the champion is has been much easier, knowing that this person cares about this problem. Understanding falls is usually one of the top 2 priorities for a hospital. And just that perspective's been
a
great.
very common challenge. I talk to hundreds of founders. They're always trying to have that conversation, find the champion in the hospital so that they can implement at a larger level. Is there anything you think you've done differently from a typical founder? And of course, you don't know what somebody else would do, but a move you've made because you had this experience in patient safety at Innova.
So one of the things that was key is we realized early on, and this was something Kinometrix learned as I was working with them at Innova, was if your solution does not integrate into the clinical workflow, it is never going to be adopted. It could be the best user interface. It could provide you with the most useful information. But if you ask a clinician, mostly nurses, to click out of the patient record, open up another screen, another app to get this information, it's not going to get used. It just won't be adopted.
Got it.
So what was key is we did not create a user interface. We're a headless system.
Okay.
We integrate into the patient record, but we seamlessly integrate into their clinical workflow.
Okay.
So for adoption, I think that is key. Understanding a two-screen solution will always fail.
Okay. Seamless, headless. It's like you don't even know it's there almost. But talk me through what the actual experience of having Kinometrix installed, how life is different. Let's say for a nurse. Are you in the ICU?
So it goes everywhere, all adult
So
patient beds.
let's just say I'm a nurse, inpatient ward. What's my experience if Kinometrix is integrated into my system?
So to understand that better, you need to go back to what they currently do. So currently, they have to manually assess a patient, built into the electronic health record, but they manually answer a set of 7 to 10 questions.
Safety questions?
Fall risk assessment
Fall risk,
questions. And those provide them with, it's a subjective assessment, so it gives them almost an inaccurate assessment.
Okay, what kinds of questions?
If medications the patient's on, age, if the patient's had a fall before, and anytime you say a patient's had a fall before, the patient's automatically deemed a high fall risk.
Okay.
Not understanding the nuances that exist in the patient record.
So unnuanced, and you're dealing with nurses that I'm guessing are overworked and probably don't have time for another checklist.
And which they have to complete each shift at least.
Wow.
ICU patients have to be assessed a little more frequently. If they were using Kinometrix, they do not have to complete that assessment. As soon as they get to the fall risk piece, they all get an automated fall risk assessment.
Okay.
The top 3 drivers or top 2 drivers of what's driving that patient's fall risk.
Okay.
And then recommended interventions based on what's driving the fall risk. So truly clinical decision support. When you think of it from a nursing perspective, as soon as you get to the fall risk assessment piece, not only do you no longer have to assess the patient or answer that checklist, you get all the information plus why that patient may be a fall risk if they are, and what intervention you can put in place to prevent it. So truly a whole clinical decision support system.
Something we talk a lot about is alarm fatigue. So is this more sensitive? Do we find more fall risks or less fall risks through this?
Less fall risks.
Okay,
so
interesting.
The subjective assessments overestimate fall risk. So at any point, over 50% of a hospital is deemed high fall risk. Which they truly are not.
Yeah.
With ours, we actually find around 25 to 29% as high fall risk at any given time. So now the limited resources you have, those interventions that you paid for, but limited in number, can be deployed to the right patients, as opposed to, I don't have 50 cameras.
If everyone's a fall risk, then it's like no one's a fall risk.
Exactly.
It's like you just can't. Okay, so it's more accurate. You said that fall risk is just the beginning. So patient safety is the goal. What's the roadmap?
So pressure injuries is what comes next, and we are talking to partners currently to develop what is going to be our pressure injuries module. Pressure injuries, similar to falls, it's a Joint Commission mandate. Patients have to be assessed for pressure injuries. Uses similarly a manual checklist. It's built into the electronic health record, but still manual. So it takes nurses time to complete it. And it's not as specific as to where the patient's at risk for developing the pressure injury, what kind of pressure injury. So that's another area that we're going to address.
So what I hear you saying is that the data needed to pull that together and understand pressure injuries is actually already in the record.
Yes.
That can be found and kind of like, analyzed.
There's multiple data points collected. You collect them on admission, nurses do assessments, labs come in, vitals come in. So there's just so much information that is not used to actually risk assess patients.
Got it. What are you most excited about for the next 6 to 12 months? What's upcoming?
The pilots we're going live with, those are exciting. We're going to have data that shows the reductions that we're looking for.
Nice.
But what's more exciting is the workforce piece for us. Are we actually benefiting the workforce? Are we reducing the burden on nurses And that's key when you're trying to build a comprehensive return on investment for hospitals. And then the resource allocation piece, we're actually letting them know what resource needs to be deployed to prevent the fall risk. So there's a cost saving there, but then there's also just a way for nurses to receive the resources they need without having to call a phone or call the central office. I need a video monitor.
It's like
That's
there in the
pulled
system
from the central office, exactly, and deployed.
I love it. I love it. Davina, thank you for coming by and giving me an update. I love how you're really tackling this from obviously the patient safety side, but also the provider well-being side. I mean, just think about just how taxing it is to be doing these assessments, and both of these come together beautifully in one platform. So keep up the good work.
Thank you. Thanks,
All
Logan.
right. All right. Take care. Be well.
You too. Bye.